Welcome, everyone. It is my pleasure and honor to be hosting another webinar today. I am Jorge Quintero, Alpha Omega's marketing manager for AOUSA. And today we have panelists from Yale School of Medicine that will talk to us about different aspects of their general anesthesia protocol for MER and LFP asleep DBS using ketamine and nitrous oxide. In part of today's agenda will include about 30 minutes of presentations broken up into a series of about 3 short presentations. The first one will be about the anesthesia protocol itself, nitrous oxide and ketamine general anesthesia, where they will discuss the differences with other asleep DBS anesthesia protocols, what are the mechanisms of action of this one, and what are the patient considerations that you should keep in mind if you want to use this in your OR. Then we'll shift to the surgical component of the protocol. How does it affect the targeting, the planning, and what are the differences in the actual MER itself compared to awake patients? And then we'll end with a presentation from the post-operative side, talking about how the intraoperative MER data from these asleep patients can be used to predict LFP-based programming contacts, as well as contact selection for adaptive DBS. If anyone has any questions throughout these presentations, definitely uh, put your questions in the Q&A box at the bottom of your Zoom window. We will reserve these for the end of all the presentations, and then we will go through them one by one and direct them to the appropriate physician. So with that, I will pass it over to Dr. Zibly, who will present today's panelists.
Hey, good afternoon or good morning. I don't know in which part of the state you are. And Jorge, thank you so much for hosting us. It's a real pleasure to be part of this panel. Today, I have the honor to have Dr. Ozcan with us. He's our chief of NeuroAnesthesia. I've been working for him for more than 2 years now, and he's been part of the team who developed this protocol. We'll also have Dr. Wang. She's a movement disorder neurologist. With her, I've also been working for 2 years. She's an amazing physician, and she will describe her experience also. Basically, today we'll be talking about the use of ketamine nitrous in sleep DBS. We'll share our experience, the protocol. We'll share with you how we choose the target, how we do the targeting. Then it will be followed by the anesthesia protocol by Dr. Ozcan. And then we'll share the MR recording during surgery, and Dr. Wang will share the programming and the correlation to the MER, and then we'll finish up with the discussions and questions, just like Jorge said. So again, my pleasure to present Dr. Mehmet Ozcan, former anesthesiologist. Go ahead, please.
All right, thank you, Zion. Okay, let me share my screen here.
Before you start, Dr. Ozcan, I want to let our viewers know that some of the data that they will see in today's presentation does come from this recent publication that came out a few months ago. Dr. Zibly actually contributed to the data that was published, and they were essentially looking at how this anesthesia protocol affects the MER and LFP recordings in STN DBS compared to awake surgery and low-dose ketamine sedation. So this study included about 100 patients across 3 centers in Israel. And again, you will see some of the data presented in this webinar, but if you want to know more, the full paper is open access. And you will see a couple of graphics that represent some tools that Alpha Omega offers. I just wanted to quickly talk about them so that everyone's on the same page. You will see some guide plots that Dr. Hawong will present, and these are considered Alpha Omega's brain mapping tool that summarizes the information in the MER trajectory, and it provides key recommendations for DBS lead implantation as you can see on the left with the lead, as well as post-operative patient programming. So surgeons and neurologists can quickly use this data to understand how the DBS was implanted in the structure, what contacts are around certain LFP biomarkers like the beta band power, and where the patient is likely to get clinical benefit from stimulation. So it's a great tool that summarizes the MER without having to look at the traces, and it can be shared with neurology or clinics to inform LFP-based programming. The second tool that you will see in today's presentation will be the Alpha Probe, which is Alpha Omega's latest microelectrode that provides 3D spatial navigation with its 4 directional micro contacts, as you can see with the gray circle, 2.5 millimeters above the tip. And so each directional contact records spiking in LFP activity, and it can inform the user of the probe's relative positioning inside the target structure, especially for the subthalamic nucleus. So with a single probe, you get 5 channels of information and insights about nearby borders. And with that, I'll go ahead and pass it to Dr. Ozcan for the first presentation.
All right. Thanks for joining. This is really one of my favorite case that I give anesthesia in the OR. So Zion joined us, Dr. Zibly joined us about 2 years ago, and came up with this plan to do these cases under general anesthesia, which was very interesting for us, and hopefully we developed it to a good degree that we are happy to share. So I will go over the reasons for choosing ketamine and nitrous oxide rather than other more conventional anesthetics, and also chime in about advantages and disadvantages about adding Precedex, dexmedetomidine, to nitrous and ketamine. And I will also go over a little bit about optimal dose ranges for ketamine, Precedex, and nitrous for good signal preservation, and also ensuring that the patients are going to be adequately anesthetized, and also share a typical anesthetic workflow at the end. So a very simple classification of anesthetic medications. Most are anesthetic medications share or we can be classified in one of the 2 buckets as far as mechanism of action. The more commonly used agents are acting through GABA receptor agonism, propofol, benzodiazepines, almost all the volatile anesthetics share that receptor for action. Another important class is the NMDA antagonists. These are ketamine, nitrous, dexmedetomidine, which is an alpha-2 agonist actually, that do not have a significant GABA agonist action. So we believe this is an important point in choosing this combination of drugs for microelectrode recording. So as Dr. Zibly will go over in more detail, we are relying on firing patterns along the trajectory as we go towards the STN, and therefore identifying the STN relies on signal characteristics, and a good effective general anesthetic while keeping the patient under anesthesia should not prevent interpretation of these signals. There is good data and some practical information that GABA agonists actually usually are counterproductive for this purpose. They are known to suppress signal amplitude and also frequencies, would reduce the firing rate, and it would be very difficult to actually get an effective microelectrode recording if we were to use GABA agonists. On the other hand, agents like Precedex, ketamine, nitrous oxide seem to have a much better profile in signal preservation, and therefore we decided and actually started using ketamine and nitrous oxide and maintain a truly general anesthetic state, not a sedative, state of anesthetic for doing these cases. Both ketamine and nitrous oxide, as I mentioned, could lead to some small decrease in the signal power, maybe summarized in a root mean square of the signal, but generally results in clinically acceptable signal quality for identifying the target here. However, just ketamine and nitrous oxide would probably give a lot of anesthesiologists a pause, if you will, with concern that the patients actually might be having anesthetic awareness, because we also rely on a good amount of muscle relaxation during these cases. So when Dr. Zibly joined us and suggested ketamine and nitrous, we quickly decided that we should probably add something else, and negotiated about adding Presidex to these two agents. While ketamine and nitrous preserves the signal quality, adding Presidex would also help reducing awareness and achieving a good, effective, appropriate anesthetic state. I would actually warn you that if you were to use like EEG depth of anesthesia monitors like bispectral index, you would not be able to titrate these drugs, because all three drugs to some extent do not have a good response in these readings. So that is something that you have to trust and not rely on this. Presidex in our practice seems to have minimal suppression on STM firing and ability to identify the target for optimal positioning of the electrode. But it adds a lot of positive things, such as good hemodynamic control. It also prevents ketamine to be used in higher doses. And while doing that, again, it seems to be quite agreeable to good signal recognition and monitoring. This is an anesthetic record, one of our actual cases, actually. Anesthesiologists probably should follow this slide through, but just to point out, on the top line, you see the timeline. We typically start the case by inducing the patient, intubating, and then starting a propofol infusion and a small amount of opioids for application of the frame, and then going to CAT scan for target planning phase. And then when we come back to OR, we actually stop propofol and start ketamine, Presidex, and turn nitrous oxide on. From 8:39 a.m. mark, you see that happening. And in this case, for example, Presidex is at 0.5 milligrams per micrograms per kilogram per hour, and ketamine is 0.5 milligrams per kilograms per hour. So this is like the typical middle of the range, dose range. And we do dose rocuronium as needed to maintain like one switch out of in a trainer for monitoring. And then for blood pressure control, we may need some nicardipine, but it's also best to avoid any beta blockers as they would also negatively affect the signals. So little trade secret, and might sound a little technical, but just relying on mics per kilo per minute dosing, just by weight dosing, if you will, may end up actually different effect site concentrations in different patients. Outside the US, actually, there are target-controlled infusion pumps that enable the anesthesiologist to choose a target plasma concentration based on pharmacokinetic models. In the US, unfortunately, we don't have these, but we actually looked at our cases so far, which is upwards of probably more than 60 or 70 of these we did. And I reversed engineered, if you will, put the doses that we are administering and see what kind of concentrations we're achieving. And although it is clinically not significant, therefore leading to a successful localization, there seems to be a slight negative effect with increasing Presidex doses, and the signal quality identified as the root mean square of the signal. Again, this is somewhat technical, but serves to make the point that at high doses, actually, the signals might be negatively affected. And when we get to the SDN, actually, the little bit of lingering propofol from the initial planning phase seems to be actually decreasing the SDN signals root mean square normalized to the above target signal for each patient. So again, this is like a pooled data for some of our patients, I think 25 or 30 of them. So yeah, in summary, again, at the doses that I showed, Presidex, ketamine, and nitrous being at about 50 to 60% end-tidal concentration, we are able to achieve good signal quality and conclude these cases successfully. And with that, I would give it to Zion.
Okay, so thank you, Dr. Ozcan, so much for the introduction. I will go on and talk about the surgical aspect of the surgery. And I will start with targeting. How do we choose the target? So, when you look at the literature, nobody really knows how to identify the STN. There's some protocols which are coming out, like, STAGE, which looks for deposits of iron in the STN, but still under investigation, and we use it sometimes. But I think that most of the people who do targeting the STN will focus on T2 or FLAIR. In the past, I used to use T2, but in the last 4 years, I think I started to use the FLAIR, which is a derivative of T2. And as you can see in the screen, you can actually see quite well the red nucleus. And as you know, the subthalamic nucleus is supposed to be laterally and a bit more posteriorly to the red nucleus. And you can see on the upper right slide, you can see both red nucleuses. And if you draw a line between the anterior part of the red nucleus bilaterally, you will be able to identify the red nucleus easily. So basically, this is how we choose the targeting. And if you look at the target coordinates, as opposed to the MC, it's usually around 10 millimeters laterally, 3 to 5 millimeters posterior laterally, and inferiorly about also, I would say, 5 to 6, which is approximately what you can see here on the right side of the slide. So this is about targeting. But beside of targeting, we have to know how to choose the trajectory, which is even, I think, more important than choosing the target. So when you do the trajectory, you have to rely solely on T1 imaging, 3D T1 imaging with gadolinium injection. The reason that you have to rely mostly on T1 with gadolinium is that you have to remember three things. You have to avoid going through the motor cortex, right? So you have to go anteriorly to the coronal suture. You can go on the coronal suture up to 1 centimeter posterior to the coronal suture, but I usually go anterior as I can from the coronal suture. You have to avoid any vessels that you see on the way. And of course, you have to avoid the ventricles and any PIA on the way. The way to do it is to choose your entry point, you know where the target is, and then look at what we call a bullseye target. So if you look at the left side, you can actually follow it along the planning system, whether you use Medtronic or BrainLab. I usually use both, just to be on the safe side. You can see the probe's eye view where the lead will go. You have to remember that the cannula is around 2 millimeter diameter, okay? So you have to remember what you're doing. And when we target the STN, you have to remember this is how the STN looks, right? The STN have two central targets. It is the sensory part and the motor part. We have to aim for the motor part, and usually we have to aim, if we can, towards the upper extremities. And this is how the STN look. I hope that most of you know how the STN looks. And we have to target to the shoulder, to the elbow, and the wrist, which is, as you can see, it's the lateral part, dorsolateral part. This is how the system looks. And as you can see in the right lower corner, this is actually a single cell recording system. This is what we do with the Microelectrode Recording system. And this is how it sounds. This is an awake case actually, and you can actually hear, once you go into the brain, you can hear, as you know, each and every part of the brain has its own fingerprint. It's both electrophysiological and you can hear the sound. And the most important thing to know is that you also have to look for a side effect, meaning that if you look at the STN, the borders of the STN, the lateral borders of the STN is the internal capsule. The lower border is the third nucleus nerve nucleus. So if you move to lateral, to medial or inferior, you'll have side effects. And this is how it sounds if you go through the different steps of the brain when you go into the STN. We usually start to do recordings in STN 10 millimeters above. If we do VIM surgeries, we start doing recordings 15 millimeters above. And the reason is because the thalamus is so big, we should be in the thalamus around 9 millimeters above. And this is how it sounds actually. When you go in, you go deeper, you go even deeper until you reach the STN. So the question is, why did we think about moving to a sleep DBS? So first of all, it's less stressful. It's less stressful for the patient, less stressful for the surgeon, which is really important. A lot of patients, when you talk with them, will ask you, do I have to be awake during surgery? And to be honest, think about it, that being awake for a few hours with a frame, having a bear hole, etc., is really stressful for the patient. I believe that if the patient is asleep, intubated, it's more easy to have hemodynamic stability. I think we have less intraop and postoperative confusion. I had a patient a few years ago in the middle of surgery, got confused and we had to stop surgery. This will never happen in a sleep DBS. We were able to reduce the surgical time, and as Dr. Ozcan showed you in his slide, says currently we do bilateral DBS STN. We are done in about 2 to 3 hours. And if we do a awake DBS, it will take us around 5 to 6 hours to do bilateral STN DBS. And again, I will show you the publication. What are the challenges in a sleep DBS? First of all, best suppression. We know that if we give a different kind of agent, we'll have a suppression of neural activity and it will damage our recording. Maybe we'll have less loss of accuracy to do the final localization of the lead placement, because you have to remember when we do DBS, we have stereotactic images. Okay, this is one part of the accuracy. We have microelectrode recordings, but if the patient is awake, we can actually do trial stimulation to look for positive and negative side effects. So when we do a sleep DBS, we actually lose the stimulation. We cannot do any stimulation. And the challenge is also to find the right protocol, the balance between the hemodynamic stability with the adequate neural signaling and firing to localize the STN. And this is a true challenge. It took us a lot of time. We did some animal studies before doing the ketamine and nitrous protocol. And as Jorge said, this is what we currently use in Yale. We're happy to be one of the only sites, actually the beta sites for the R&D with Alpha Omega. We are currently using the Alpha probe, and this is how it looks. As Jorge said, we have the central tip, which is the old version of the Microelectrode Recording, and we have an extra 4 contacts in the surrounding, but a bit above the STN. So when we go in the STN, we know exactly when we went in, and we can actually imagine the 3-dimensional shape of the STN. Are we really in the STN? Which part of the STN are we? Are we in the middle of the STN, the posterior part, the medial part, the lower part? Did we miss the STN? Why did we miss the STN? And this is really helpful, and you'll see in a minute how and why. This is how it looks. As Jorge said, I don't want to talk about it again, but there's a tip, and there's 2 millimeters above the tip. There are 4 contacts in the 360 degrees setting. And this is how it looks. So when we go into the STN, this is when we are above the STN, so we can't hear anything. And you can see the big slide on the left is the central contacts, and the other contacts are the anterolateral, the posterolateral, the anterolateral, etc. So when we go in, and you can see it's still quiet, we are still far away in the STN, and in this slide, actually, we are 6.5 millimeters above the target. we go deeper, and now we are touching the STN with the central contact, and you can see that only the central contact have the recordings from the STN. It's you can hear the density of the cells, but it's still quiet in the 360 degrees. And the reason it's still quiet, it's not because we missed the STN, it's because the 360 degrees contact are 2.5 millimeters above the STN, and this is how it sounds from the central contact. Okay, so this is the STN, and I apologize, we can only record 5 seconds of each step we go. And as we go into the STN, the aim of surgery is to have all the contacts in the STN, so you will know that you are apparently in the center of the STN, and you can have a big bulk of the STN to implant the lead, and this is how it looks. So this is the STN, this is 0.45 millimeters above the target, and as you can hear in the morning, you can see that the central contact is in the STN, and all the 360 degrees contacts are also in the STN. Okay, so this is actually give us the confirmation that we are in the right contact, we are the right target, sorry, we have all the leads are in the STN, and when we go through, we might encounter the SNR, and this is how the SNR looks in the central context only, of course. So this is the SNR. So as Dr. Ozcan said, we published the study, and it was a multi-center study. Yale was part of the study together with three other centers. We had a huge number of leads implanted, and we compared awake DBS as compared to ketamine and nitrous and a combination. And a few interesting findings we had. So if you look at the length of the STN, actually there was almost no change in the length of the STN. When you look at awake as compared to ketamine and nitrous, the bulk density of the STN didn't really change. It was almost the same when you compare awake to ketamine and nitrous. And when we go on and see and look for the beta oscillation, there was a bit reduction in beta oscillatory activity when compared to ketamine to awake, but I wouldn't say that it was so big. And if we look at the beta ratio and the frequency, the difference becomes even lower when compared to awake. This slide is also interesting so it's A, B, and C. Let me move something. So if you look at A, B, C, and D, A is the amplitude compared to time. B is the mean firing spikes of the STN with the coefficient. C is the distribution of the firing rates, and D is the LFP spikes triggered average. So you can see that there's not really any difference, not big difference when you compare awake to nitrous and ketamine patient. So what does this mean? What does it mean? It means that basically, and again, I know that most of you are familiar with this, and this is how we implant the lead. You can see in both the left and the right side, we went in about 6 millimeters above the target, and all the way to minus 0.1 millimeter, we were still in the STN. It was more than enough to implant the leads. Usually, we like to implant, number 1 and 2. This is Medtronic's lead, so the way they number it is 0, 1, and 2. We usually like to have 0, 1, and 2 in the context. I know the donologists mostly use number 1 and 2, but as you can see, both 0, 1, and 2 and half of 3 are in the STN, and we could also see that we have, this is the heat map, we can also have beta oscillations with the ketamine and nitrous. So we can actually do have some beta oscillations for accuracy of the motor part of the STN with the nitrous ketamine. So for conclusion, for surgery, we showed that nitrous ketamine general anesthesia allows a good satisfactory microelectrode recording for the localization of the STN despite a minor decrease in the overall activity of the STN during surgery. The overall activity, as Dr. Ozcan said, of the STN is decreased by a small amount during nitrous ketamine anesthesia. It is possible to recognize with high confidence when we enter the STN and when we exit the STN, which is really important. And the big question that we are checking now, hopefully we'll have the result in the next 2 months, how can we use the delta spikes to make the localization of the STN even more accurate?
All right. So neurosurgeons like yourself does amazing job. Like what Dr. Zibly say, avoid the ventricle and vessels and motor cortex. And after 30 days of DBS placement, neurologists like myself do the programming. There are several technology that we use to program, but I use brain sense technology from Medtronic. So we use LFP PIC to program the patient combined with the clinical finding. As you can see, I'm going to compare the MER in the OR data versus the LFP data that I see in Branson survey. Here, the MER data, you can see the best peak signal, highest signal in electrode 1. In Branson survey, also had a highest LFP peak between 1 to 3. The Branson survey analogy is very similar to EEG. It means that the best peak is either in electrode 1 or electrode 3. And I used rational deduction and comparing 1 to 2, 0 to 1, or 0 to 3, and 2 to 3. And then I picked the best electrode. Usually it aligns well with the MER data. Another example here, the best MER data in 0 and 2, probably 2. And same in Branson survey, I got the best peak, LP peak at 0 to 2, meaning the peak is either in 2 or 0. And similarly, I do rational deduction to compare all these different peaks and determine the best electrode to stimulate. Another example here, you can see the MER is strongest peak between 1 and 2. And when I did Branson survey, the strongest peak at 1 to 2C. So in Branson survey, we call it segment. So when electrode is cut horizontal, we can actually stimulate in different direction. And Branson survey is able to detect the best peak at the different, based on the segment. And in this Branson survey, it gave me the best pick at 1C and 2C. And using the rational deduction, I'll be able to pick the best electrode, either 1C or 2C. And this is very helpful, especially with the patient who has a lot of side effect with the pulling or something like that. If the internal capsule gets stimulated, then we can use this directional to guide the stimulation. Another example here, the 9 and 10 is the best. And voila, in Branson survey, aligned pretty well. I had a best LFP peak at 9C and 10C. And as you can see, the LFP peak is pretty good. And Branson survey has been pretty well, worked pretty well. Sometimes the patient's objective finding is not so discrete, then I sometimes use Branson stream. So I use LFP stream the LFP at the time while I was programming. So I increase the LFP, increase the amplitude stimulation, and I can see the LFP is going down. And I know that stimulation is working and I'm in the right place. So all this is great. What is the future? Why are we talking about this? So the future is adaptive DBS, which is also called closed loop DBS. So open loop DBS is our what we have been doing. The clinician stimulates the patient, look at the clinical finding, and we program the patient. Now there's a closed loop DBS where the machine using the biomarker of electrophysiology like LFP or MER, they're able to detect and learn the clinical state of the patient and then stimulate the DBS or turn it off. So this is the closed loop DBS, and Medtronic recently developed the adaptive DBS. So we, the neurologists, pick the best peak, LFP peak, and then we put as a biomarker. And then we look at the amplitude and their clinical finding, and we put the threshold. One way is putting dwarf threshold, and the other way is putting just single threshold. And then we tell the machine to stimulate or turn off the patient. So pretty much the machine detects the clinical state of the patient based on the LFP, and they can stimulate the patient, and that goes in the loop. The machine is able to do that. That is set by clinicians like myself. So another good thing about the MER and brain sense is dystonia or myoclonus, Parkinson or essential tremor, like stiffness, rigidity, or tremor. They respond pretty fast with the stimulation. However, dystonia and myoclonus response can be very slow, a month or even longer. And so when we do stimulate, there's really no man's land and we're stimulating. And I asked order generation programmers and they say, yeah, we don't know what to do. So we'll just double monopolar, triple monopolar, just increase the stimulation. But now I use brain sense to look at the peak and pick the best electrode, and then I stimulate. So for dystonia or myoclonus. So LFP-based programming works pretty well, especially with the MER, the current anesthetic protocol. So that's it. And thank you so much for the talk. And any questions?